Assalamu alaikum. Good day, everyone. Thank you, Hadeel. I'm Raghad AlHarthi, medical intern. Recently got accepted in Riyadh Dermatology residency program at King Abdulaziz Medical City. First of all, I would thank the Derma Club members for inviting me to give this talk. Special thanks to Dr. Lama, Hadeel, and Al-Anwar. I'll be talking today about the most common cutaneous disorder that affects approximately 80% of the population at some point of their lives. As we all know, June is the National Acne Awareness Month, so it is a good chance to raise awareness of acne. This is our outline for today: definition and epidemiology of acne, the causes and pathogenesis, diagnosis and clinical presentation, and finally, the management. First, I will start with this question: what is the difference between acne and acne vulgaris? And what does vulgaris mean? Anyone want to answer? Do you hear me?
Everyone, you can use the chat to talk if you'd like to participate with Dr. Raghad.
So I will answer it. Vulgaris means common. So acne vulgaris means the common acne. Acne is the general term and it has several variants like neonatal acne, acne fulminans, and acne conglobata. Since our topic today is acne vulgaris, I will explain each one of them briefly. So neonatal acne occurs in more than 20% of healthy newborns. Lesions usually appear at about 2 weeks of age and generally resolve within the first 3 months of life. The lesions are usually small, inflamed papulopustules. Acne fulminans is the most severe form of acne and is characterized by the abrupt development of nodular lesions in association with systemic manifestations. It usually affects boys from 13 to 16 years of age. Acne conglobata is a severe form of nodulocystic acne that may have an eruptive onset but without systemic manifestations. Let's move to the definition and epidemiology of acne vulgaris. Acne is a multifactorial disorder of the pilosebaceous unit. This figure shows the pilosebaceous unit, as you can see here, the epidermis, the dermis, the hair follicle, and the sebaceous gland. Acne fevers the sites with well-developed pilosebaceous glands, like the face, the upper arms, and the chest. And it has a profound psychosocial impact. It has been suggested that patients with moderate to severe acne suffer from poor body image, low self-esteem, and experience social isolation and constriction of the activities. As part of the emotional impact, they will have some level of anxiety, anger, depression. Regarding the epidemiology, acne is considered the 8th most prevalent disease worldwide, affecting around 80% of people between 12 to 25 years. And in 40s, acne prevalence is 26% in female and 12% in females. What about our population? I found one systemic review includes 5 studies, and the findings suggested that the mean acne vulgaris prevalence was 54% among males and 54% to 84% among females. Let's move to the next objective, the pathogenesis of acne vulgaris. There are 4 key elements of the pathogenesis. The first one, abnormal hair follicle differentiation. In normal follicles, keratinocytes are shed as single cells into the lumen and then excreted. In acne, keratinocytes are retained and accumulate, so the follicles become blocked with an overabundance of normal skin cells. These cells combine with the sebum, which is the oily substance that lubricates the hair and skin, creating a block in the follicle, as we can see in this figure. The second mechanism, the sebaceous gland hyperplasia and excess sebum production. Sebaceous follicle size and number of lobules per glands are increased in patients with acne. This process is most prominent during puberty because androgens stimulate sebaceous glands to enlarge and produce more sebum. The third one, the presence and activity of Propionibacterium acne. Recently, it was renamed Cutibacterium acnes. These gram-positive non-motile rods are found deep in the follicles and stimulate the pro-inflammatory mediators and lipases. While there are maybe increased number of C. acnes in acne, bacterial counts often don't correlate with the acne severity. Inflammation and immune responses. Inflammation occurs as a result of bacterial overgrowth. This can lead to the rupture of the follicle and the formation of a red tender pimple, as we can see in this figure. These mechanisms will lead to the formation of blackheads and whiteheads in mild acne, then papules and pustules in moderate acne, cysts and nodules in severe acne. Next, the causes and risk factors. I listed here the main risk factors for acne vulgaris. The first one is age. As I mentioned earlier, it's common among adolescents, but it can affect any age. Then, genetic factors. The number, the size, and activity of sebaceous gland is inherited, and several studies showed that there is association between acne and family history of acne. External factors, the use of oily products or oily cosmetics may contribute to the development of acne. Also, hair oils can worsen skin lesions. Hormonal changes. In most people with acne, hormone levels are normal, but in acne, the sebaceous glands become highly sensitive to the hormones. So hormonal changes during adolescence can cause sebaceous glands to become enlarged and sebum production increases. Also, women can have acne flare before the menstrual period, especially in women older than 30 years. Endocrine disorders. People with endocrine disorders such as PCOS, polycystic ovarian syndrome, hyperandrogenism are more likely to have acne. What about dietary factors? The role of diet in acne is controversial. Some studies have found weak associations between cow's milk and an increased risk of acne. However, there is no strong evidence that milk, high-fat foods, or chocolate increase the risk of acne. Medications. Acneiform eruptions can be caused or exacerbated by some medications, including androgens, steroids, antiepileptic medications, and lithium. The rest of the medications are shown in this table. Stress. Some studies showed that sebum production did not appear to be related to stress, but acne severity did appear to be associated with stress, especially in males. Obesity and insulin resistance. Insulin and insulin-like growth factor can stimulate keratinocytes and sebaceous glands. So elevated insulin growth factor levels are found in women with post-adolescence acne. And obesity has been found to be associated with an increased prevalence of acne in people aged from 20s to 40s. Let's turn to the third objective, diagnosis of acne. Acne in general is diagnosed clinically from the patient history and physical examination. But if virilization, menstrual irregularity, or hirsutism is seen, we have to evaluate for hyperandrogenism. Also, medication history should be reviewed for acne-inducing drugs I mentioned earlier, and the skin should be examined carefully since the assessment of the skin type and the location of the lesions is critical for determining the most appropriate treatment. This table summarizes the main key points in the history and physical examination. So in the history, the gender of the patient, the age as it's common in adolescents, degree of motivation for treatment, the occupation, lifestyle, the current and previous acne treatment, the use of cosmetics, especially if they have oily material or substance, menstrual history and oral contraceptive use, medication, other medical conditions, and family history of acne. In physical examination, of course, the skin type, skin color, the distribution of acne, and overall degree of involvement, if it's mild or moderate or severe, because this will guide us to the right or appropriate treatment. The lesion morphology, the post-inflammatory pigmentary changes, the scarring, because it's one of the indication for starting oral isotretinoin, and signs of virilization. We can classify acne lesions into inflammatory and non-inflammatory. Inflammatory acne manifests as white heads, the closed comedones, and black heads, the open comedones. Inflammatory lesions begins as microcomedones but may develop into papules, pustules, nodules, or cysts. Both types of lesions are found in areas with dense sebaceous glands. Here, acne grading and classification. As we can see in the first picture, mild acne, we may see few non-inflamed blackheads or whiteheads, and the numbers usually less than 20. In moderate acne, we will have more comedones and pimples, sometimes larger, more inflamed pimples or pustules. In severe acne, we may see large red painful pus-filled lumps or nodules that sometimes even join together under the skin into a giant abscess. Turning our attention now to the management, actually there is no single best treatment for acne, and combination of treatments are sometimes recommended. And since acne lesions take at least 8 weeks to mature, we should use the treatment for a minimum of 2 to 3 months before deciding if the treatment is effective or not. So in mild acne, we use topicals like topical retinoids, topical antimicrobial. We may use salicylic acid or azelaic acid as a second line. In moderate acne, we have to add oral antibiotics plus the topical retinoids and benzyl peroxide and adapalene. In severe acne, we may start oral isotretinoin or oral adapsin, high dose of oral antibiotic as a second line. And we also have some procedural options. In mild acne, we have comedone extraction. In moderate acne, we may have intralesional corticosteroids, and also we can have it in severe acne. You can take a screenshot of this table because it summarizes the acne management in a very well way. These are my resources. Thank you all. If you have any question, don't hesitate to ask.
يعطيك ألف عافية دكتورة رغد. The presentation was really wonderful. I really enjoyed it personally. لكل attendees, if you have any questions, please feel free to use either the chat or the Q&A feature. We'll be happy to read دكتورة رغد your questions. مبدئيا دكتورة, one of the attendees would like you to please go back to the slide that displays the treatment so that they can screenshot.
Okay. Any questions?
أيوة دكتورة, في a question. One of the attendees would like to know if it's still in practice to measure a liver function test with triglyceride levels for patients on oral isotretinoin.
Usually, we do these basic labs first, and in each visit, sometimes it takes 3 months, we have to repeat the tests. Since one of the known side effects of oral isotretinoin use is increased level of and changes in lipid profile.
Okay, Dictora, I think these are all the questions.